Good afternoon, everyone. It's a great pleasure to start with the event, with the session for the fellows. It was a great pleasure to present the moderators and the panelists. Is Dr. Rigatelli, Dr. Chicu, Dr. Stoyanov, me, myself, and we're waiting just for Professor Vasilev. And because we are already late for 5 minutes, we're going to start with the first presentation, and it will be from Professor Rigatelli for the coronary angio, the gold standard and beyond.
Good morning to everybody. I'm very pleased to be here again in Sofia. All right. So, the title of my speech is Coronary Angiography, the Gold Standard and Beyond. Actually, some memories. Here, I was 9 years old. I won my first North Italian Shotokan Karate champion, and I went regularly to the cath lab of my father, watching the coronary angiography in 1980. I was not far from the hospital, so I went by bicycle in the afternoon, and I watched the first procedure there in the afternoon. At that time, brachial cut down. You should have a good surgical skill, and catheter, diagnostic catheter, were 8 or 9 French, and I clearly remember the technician who prepared the catheter, because the catheter at that time were customized on the purpose for the day, and they cut the tube, they put the back of the catheter, and they preformed the shape of the catheter at that time. And there was a lot of analogic technology. And to me, all this kind of technology was amazing, was fascinating. I thought about me like Goldrick and his spacer. So afterward, the coronary angiography evolved a lot, and for many things, other stuff in the world, the history is an history of evolution. And from the start, before 1970, at least in Italy, we got coronary angiogram in 1958, and then we have improved machine. And then we came to the fractional flow reserve, to the OCT, and other stuff that we'll see during the afternoon. If you look into the 1950 machine, it's like to using the periscope of the submarine, and it was hard to get it through the imaging and to guess if there is or not a coronary artery stenosis there. In 1960, the situation clearly improved, but the bed was not movable at all at that time. But nevertheless, the imaging quality improved. And in the 1970s, there was a lot of angiographic machine with a movable bed and a movable arm. Coming to our days, where we have a lot of stuff into the cath lab, and the machine are capable of very low radiation dose. We have a rotational angiography that we use quite a lot. We have a virtual roadmap. We have a stent enhancement. We have everything. But things often are not what they usually appear to be. And we came to the Achilles heels of coronary angiography. that is based upon the fact that we have no the third dimension, so we have only two dimensions, and sometimes the central stenosis are not really clearly visible in 2 or 3 orthogonal planes. To overcome this fact, we use a lot of ancillary technology, and but still in 2020 the resolution power and the accuracy of coronary angiography is not optimal. And if we mind to these pyramids, we saw that invasive coronary angiography has a diagnostic accuracy of only 65%. We try to improve this accuracy using resting physiology, using cost FFR, using FFR, and we don't know what is the additional value of QFR, MUFR, and we guess that for sure CT and IVUS improve our diagnostic accuracy. We know that the coronary angiography alone is not able to detect all the stenosis with reduction in myocardial perfusion. And we know that compared with IVUS and OCT, coronary angiography has got less power to detect significant stenosis. But in this very recent paper in JAMA, we learned that probably QCA-guided PCI is not inferior to PCI using IVUS just because of the IVUS background of the operators. Coronary angiography has evolved in his way, and we use more projection, we use more angulated projection, and the armamentarium of the coronary angiographer in 2020 is plenty of different projection and of new projection also. This is a reverse spider view that we use for a left main bifurcation disease. And nevertheless, we still need something more to be sure that our lesion is a real significant lesion. And recently, we get a three-dimensional quantitative coronary angiography, and we learn that with three-dimensional QCA, the accuracy of the coronary angiography improved a lot. And much more, we are, obviously is the focus of this meeting, we rely on FFR to standardize our procedure and reclassify some three-vessel disease into one or two-vessel disease, or on the opposite, on the basis of FFR technology. Other additional tools in improving accuracy is the CFD simulation that results in virtual and online physiology based upon two or one, even one coronary angiogram. And that is an amazing improvement because we can really assess online not only the functional index, but also probably in the future the areolytics parameter of the coronary lesion. And probably in the future we will be able to put into our flowcharts also the newest technology such as the contract QFR or the MUFR. But in conclusion, invasive coronary angiography has evolved during the last 50 years from diagnostic tools to an interventional integrated procedure using more radiological views, integrating some ancillary technique like FFR, OCT, IOS, and probably is not anymore a gold standard for every operator, but is still reliable to diagnose significant arterial lesion. And in particular, I think that for expert operator with a strong imaging and physiology background, it can still be the gold standard with the aid of stress or perfusion tests. Thank you so much.
Thank you very much. If there are any questions or comments.
So welcome from my side. And just because I see that we have 4 minutes for questions and some discussion, Gianluca, what do you think about the future of coronary angio? Because, the low quality angiography is probably worse than the well-performed CT imaging. But by reverse, sometimes there is patients, and this not so small number of patients who need invasive assessment, especially now, which is the topic of this year meeting of BBC, about the functional assessment, and we are now switching from invasive angiography just for diagnosis to interventional diagnostic procedure for the assessment of microcirculation. So what is your opinion about the future of coronary angio?
Because I'm an interventional cardiologist, and from all my life I rely on coronary angiography, I'm prone to think that there will be a future for invasive cardiology, because if not, I have no chance to provide food for my family. So, but nevertheless, with the photon counting CT, and it will be in our hospital probably within 5 years or 6 years, and we will get an optimal visualization of the coronary artery, and we will be able to have a functional assessment before doing coronary intervention. I think that this technology costs a lot, so I don't believe that we can afford, at least in Italy, we cannot afford photon counting CT for every kind of patient. So I believe that there will be still space for coronary angiography in the future. The problem is that the young people are not so skilled in coronary angiography. I mean, they are skilled like interventional cardiology, but they're not skilled in coronary angiography. So,
yeah. Yeah. Juan?
Actually, I think that the future of the angiography is now expanding, because every day the computational physiology based on angiography is improving quite a lot. The accuracy is amazing, and not only for assessing QFR. Now you can assess strain, you can measure the velocity, the microvascular function, based on a good quality angiography. So I think that's the key point.
This is why I said good quality angio. That was my the key word is good quality angiography.
Yeah.
Okay, it's time to move forward, and I would ask Professor Gio to deliver his presentation. It's going to be intravascular imaging when, what, and how to use. Please, Professor Gio.
Good afternoon. Thank you very much for this invitation. I really appreciate to be here again with you. The task for today isn't not so easy. Probably we should start with the sentence that since 1 year, intravascular visualization became 1A indication for usage in interventional cardiology. We should keep it in our mind. This is not just, intravascular ultrasound and optical coherence tomography. They are not just toys, but not also scientific tools, but practical tools for every single day practice. There were a lot of words said about coronary angiography. I would like to bring you to the facts that I love this sentence used by Professor Rigatelli, that we need more. Yes, this is true. We need some more to add to classical, good coronary angiography. We have two options, by the way, in nowadays. This is just go back, sorry. No. This is intravascular ultrasound and optical coherent tomography. Here you can appreciate the differences from physical parameters. And of course, these physical parameters impact the final image and the image itself. So we should keep in our mind that with IVUS, the penetration is deeper. With OCT, the precision, because of the bigger resolution, is much higher, however, limited to the, let's say, 2-3 millimeters of the vessel layer. And of course, in terms of interpretation of the image, we have to take into account some differences also attached or associated with these physical parameters already mentioned just earlier. Because in IVUS, shadowing means mainly calcifications. So the same in OCT is just attenuation with let's say, caused by a sudden signal drops off. And with these both techniques, especially for healthy vessels, it's very easy to differentiate 3 layers of the coronary artery wall. We should keep in our mind that the first layers, intima and media, are attached or associated with atherosclerotic process. And in this effect of atherosclerosis, we have a complex of media plaque. However, we can rely on these images. There's a very high accuracy compared to histological specimen. And here you can appreciate these matched images of OCT and histological specimen. This is very important, that there is a tendency to decrease the dimensions by OCT and increased by IVUS. This is not one-to-one. It's very important to keep it in our mind, because we have much more, let's say, digital parameters, so-called cutoff criteria, which are very helpful for practical interventional cardiology. However, this is not one-to-one, because these two techniques. In terms of possibilities and informations collecting by these two techniques, I propose you to go with me in this kind of tour. Here you can appreciate the three types of atherosclerotic plaque characterized by IVUS. This is soft, fibrotic, and calcified. The third one is a mixed, so at least 2 of these features in one image. Mostly this is calcific or mixed. However, For acute coronary syndrome, we can appreciate, we can see very often also soft lesions. Here you can appreciate the same types, but recognized by OCT. You see the differences in images, the color, the shapes as well. However, we can really appreciate, we can really differentiate a lot of elements of atherosclerotic process within the vessel wall. And of course, we know that dissections are very often findings during the interventional procedures. You can appreciate on this slide that we can differentiate these dissections by the depth of dissection within intimal and medial dissections, intramural hematoma is quite often as a consequence of dissection. But by the way, with OCT, we can find the same. Of course, the differentiation is different. We need, let's say, some experience to recognize all of the parts. However, we can say, yes, it's available also with OCT, despite this less penetration compared to IVUS. Here you see intracoronary thrombi. You know, this is I would say this is one of the best aspects of OCT usage, because with OCT, as also microscope view, we can appreciate not only the presence of thrombus, but also differentiate between red and white. And of course, we know that due to this fact of mechanism of acute coronary syndrome, everything what is associated with the clinical scenario of this syndrome is located on the surface of the vessel wall. So therefore, with OCT, with a higher resolution, we can quite easily appreciate the plaque rupture, erosion, and types of thrombi. Also with OCT, it's very easy to understand and to differentiate the neointima hyperplasia. You can here appreciate that not only this neointimal hyperplasia, but also the thrombus presence we can differentiate with OCT. And on the left side, you see the IVUS image, and this is the problem of IVUS. The differentiation between soft plaque and thrombus is not very easy. Here you can appreciate the kind of complex, at least with two parts of tissue. One is mostly, let's say, close to the stent. This is probably neointima proliferation, and inside it is a part of thrombus. So this is the weak part of IVUS, for example. But of course, using IVUS, which we know from the guidelines of European Society of Cardiology, also American societies as well, that this is a very important indication to appreciate, to differentiate the mechanism of restenosis. So with IVUS, we can do that relatively easy. However, also with OCT is possible. Today there was mention about quantitative coronary angiography, because we have also a quantitative IVUS and quantitative OCT. And here I appreciate a very old slide from the beginning of 21st century, where we established in that time a couple of digits which were helpful in the decision-making process during the practical actions in cath labs. I don't want to go into the details, because And nobody believes today in 4 square millimeters that is a good lumen for every single patient. However, just to keep in your mind that you can easily calculate all of the parts of vessel and atherosclerotic process. And also with this, using pullback or pullback maneuver, we can appreciate also the remodeling process, which can be positive, negative, or just neutral. But of course, with OCT, the same is possible. It's available, even because of the faster pullback. It's obtained quite easily and very easy and very fast. In terms of post PCI findings, so here you can appreciate the possibility of assessment for stent apposition. You can appreciate the stentage dissections, stent fracture, also tissue protrusion, especially for soft plaques. And you can appreciate that theoretically it's easy to recognize these details with OCT. This is the problem of today, that young cardiologists, it was mentioned today, they believe in images, and what more, they believe in softwares which facilitate the interpretation of the image. So this is the advantage and superiority in nowadays of OCT assessment, which is prepared by the companies automatically using AI, which is a lack for IVUS. However, as far as I heard, it will come very soon. This is a moment to discuss about the biggest enemy of interventional cardiologists, which is calcium. You know, IVUS, we know this is very important. This is, I would say, this is right like a religion slide for IVUS user by Gary Means, and you can here appreciate how we can assess the localization and amount of calcium, looking at the arc of calcium, the localization, superficial or deep. And what is very, let's say, fashionable during last 2 years, also calcific nodules. Here you can appreciate with these big arrows typical calcific nodules. But this is also available with OCT. Even much more, let's say, much more precise, I would say. However, in terms of calcific nodules, you can appreciate here the proposal of differentiation of types. This phenomenon, I would say. So I'm pretty sure that 5-10 years ago, the same images wouldn't be assessed as a calcific nodules. But here, if you look very precisely, when you see that there is no connection between parts of these calcific rocks within the vessel, you can recognize really even a lot of calcific nodules, not just 1 or 2 within the vessel wall. But also with OCT, you can appreciate here, you can also differentiate superficial, deep, concentric, eccentric, and nodules, calcific nodules with OCT. Why it's so important? Because we know that there is a very straightforward relation between the amount of calcium and the results, let's say, ad hoc results of PCI, and also it impacts the late follow-up of the patient. So therefore, there are some proposals, some algorithms proposed by many centers which allow us to standardize this assessment and assess just in terms of need to use much, let's say, more tools than only balloon and see or cutting balloons, but when we need much more atherectomy, orbital or rotational or intravascular lithotripsy. And here you can appreciate one thing. I would like to bring your attention to the fact that with the IVUS, there is only one big problem with the assessment of depth of calcific or thickness of calcific layer, which is very important as one of the part of this calcium scoring system proposed for OCT. But we found with IVUS that we can assess, we can adapt this OCT scale for IVUS, and this is also, let's say, possible. And both methods, OCT and IVUS, for calcium assessment within vessel wall, we can translate into this algorithm for optimal management of coronary calcific lesions when and how we can use additional tools as rota or orbital atherectomies or intravascular lithotripsy. Just to start summarizing this lecture, I would like to bring your attention that we know from many, many years that with IVUS we can really change the protocol of the procedure. And Professor Rigatelli is right that when very good experienced angiographer starts to perform procedures without direct usage of IVUS, but with the experience of IVUS, when he used this kind of correction of IVUS, which is typical for France, where the IVUS is not, and OCT is not reimbursed, the results can be quite good. However, we are not all the France guys. We don't have such a big experience as Professor Fajadet or other very good French interventionalists. However, you have to believe that your primary protocol of PCI may be completely changed by the image, let's say, achieved pre-interventional. We also know from the literature that some findings during, and post-PCI is translated into the or associated with the late follow-up of the patient. So it means we have to be completely sure that the final result is optimal, and then we can rely on our job. If not, so this is our responsibility in terms of our patients, that we didn't do our best. Remember, in ESC guidelines, IVUS and OCT started, let's say, became 1A indication to use. And of course, due to the collected a lot of data based on impact of IVUS or comparison IVUS and angio as impact for final outcome of the patient, there is a superiority of IVUS over the angio. This is for sure. It is not only for chronic coronary syndrome patient, but also for acute coronary syndrome patient, as you can appreciate here. Left main, this is a special animal, I would say, for interventional cardiology, but also here, because of relatively good correlation between physiology assessment and IVUS, we can appreciate on minimal cross-section area for left main in terms of qualification for potential intervention on left main. And here you can appreciate this proposal that if this MLA is more than bigger than 6 square millimeters, we have to forget about PCI. If we have less than 4.4, this is a need for revascularization. If you have this shadow range between 4.5 and 6, If we have any doubts, there is no clinical confirmation of this MLA, so we have to use functional assessment. So this is a Kang proposal 5, 6, 7, 8, when we can use in our procedure, let's say, to differentiate yes or not. However, this is all based on IVUS. In nowadays, we know that for Caucasian people, we have to increase at least 1 square millimeters for all of these digits. We have also assessed the need for second stent for distal left main bifurcations using IVUS, believing that these square millimeters, less than 3.7 square millimeters, and plaque burden bigger than 56, there are additional information that after stenting across circumflex artery will need additional action for, let's say, to keep a good result. And just at the end, when and how, so we have to keep in our mind these clinical scenarios. If we have people, we have the patient with a kidney injury, you have to remember that contrast medium is nephrotoxic. So we have to appreciate to use as less as possible. So zero contrast IVUS, it's available. It's very helpful for this kind of patients. For acute coronary syndrome patients, where we need to know the mechanism of the situation, OCT is much better. If we have high IVUS definition, because IVUS and IVUS is not always the same, so we can really believe that IVUS is not, let's say, worse than OCT. And the final slide, here you can appreciate in which situations, during the PCI and post-PCI, also during the follow-up assessment, which of this technique you can use. But I will tell you at the end, doesn't matter OCT or IVUS. The most important is the need of the patient to optimize the final result. The visualization is the need of today. And you can use this technique, which you feel more familiar, which you are much more experienced. Anyway, one or two, they are not. This is not a contest. We shouldn't think what is better, what is worse, but we should remember about the limitations. The one limitation, for example, this is osteal lesions for OCT. It's impossible to properly assess with OCT, for example. These kind of limitations are well known, and what I would you to suggest is just to know two techniques, and taking into account the need of the patient, availability of this technique, you can use one of these two. Thank you very much for your attention.
There is any question? I have one. In Italy, there is a tough battle among people that are pro to learn Latin in school, and people are contra to learn Latin in school because it's outdated. And I consider, if we speak about artificial intelligence to apply to imaging, do you think that is to do not learn Latin at school, or the opposite? It will help, or it will destroy just the natural intelligence of the young generation?
I don't want to complain on the young generation, because they are different, and but they are great and different than our generation. One is for sure that nowadays the people, human being, used to look for easiness of life. So therefore this learning of Latin or self-assessment of Ivor's image is a wasting of time for them. That's true. And this is a very bad approach, because you have to you keep you in your mind with the OCT, even having 1/3 of the vessel wall, you can reconstruct the rest. So what I suggest always to young colleagues, okay, if you like OCT, do OCT. But at the end, look just but yourself for all of the, let's say, vessel recorded, that just to be sure that this is the real. Because just putting the let's say, button and just to ask the technician about the numbers, this is a drama, I would say. It shouldn't be like that. But I was not one or two times the witness of these situations. The people perform OCT without interpretation of the image, just taking into account only the numbers.
So probably is still better to learn Latin at school.
Yeah,
Right.
yeah.
Okay.
I learned Latin. I still remember something.
Thank you so much.
Can I ask you something,
Oh, yeah.
Robert?
Yeah.
Sorry. In this context, just a comment of what Gianluca said. Probably we were in the same path when we were studying phonocardiography. You're asking, Jesus, why should I learn this? But it is very important to understand the mechanism of murmurs and so on. But if we have to decide, for example, we have, like, in most of the places, we have a limited budget, and you should decide what kind of intravascular imaging one should achieve. What is your proposal? And
IVUS.
Probably what?
This is IVUS. Why? Because first of all, you can really limit the contrast medium for every single patient. You can perform procedure, also interventional, for the patient without kidney. I would say, this is one. The second. Maybe I shouldn't mention about that, but this is reusage of the catheters, which also should be taken into account. There are some possibilities to resterilize according to the law, and in countries with low budget, it's done. We did it in the past days. So also from these, what else? I would say that if I look at the daily usage, I don't remember when I had to repair my IVUS machine. For OCT, this is very often. So
I feel more comfortable now.
Yeah.
Anyway.
Any other question? We can go, thank you, Gil. Thank you, Robert. And we can go ahead with the next speaker. I introduce you Professor Chico, Spanish man but German-based, and coronary physiology in the cath lab, when, how to use, please.
Thank you very much for the kind introduction. This music that you heard is the leitmotif of the Rhine River in Wagner's tetralogy. So I don't lose the hope of getting you addicted to Wagner music, even in this unsuitable scenario for that. We are going to talk about physiology. My friend Johannes van der Root who probably you know, divides the cardiologists in two groups. Those who use the pressure wire for everything, and those who use imaging for everything. I say that there is a third group, which is even bigger, and it is those cardiologists, interventional cardiologists, who neither use pressure wire nor imaging for anything. And actually, this is the reality. The majority of interventional cardiologists think that they are blessed with unusual eyeball capabilities, and that physiology, imaging, they don't need that because they have 30 years of experience. But actually, the standards that we have now, we have evidence, we have technology. The standards from 30 years ago are not acceptable anymore. And that's your first task or your first duty as young fellows, is to change this current situation. And the current situation is, notwithstanding the compelling evidence of physiology, the penetrance of physiology in the daily routine is very low. Why? First of all, we have to accept it. It is cumbersome. Every time you say in your cath lab, we are going to do FFR, there is at least one nurse who is making funny faces. I have to go early, go back home, etc., and so on. Also, not to disregard the discomfort that the hyperemia is provoking. And in some countries, this dichotomy between imaging and physiology, because Germany, for instance, only one ancillary tool, one toy, is reimbursed. So if you use physiology, you cannot use imaging. Or if you use it, the hospital will have to pay for that. And sometimes you have to take decisions in this regard. Anyway, let's start with the official recommendations in the guidelines. The ESC has decided not to publish any more guidelines about myocardial revascularization. And for us, as interventional cardiologists, it's disappointing because you will see that the indications that we have in the current guidelines are not so clear from a technical point of view as they used to be. We have to go to the guidelines for the chronic coronary syndromes, the management of the chronic coronary syndromes. And you see that the formulation is not so clear, but translated, it is, the physiology is indicated in intermediate stenosis between 40 and 90. You know that, but 40 and 90 by visual assessment. You do not need to do QCA. It's your visual estimation. So be aware of the subjectivity that this indication implies. And you know that by convention, all the lesions more than 90% are translated into the TIMI flow. So if you see that the TIMI flow is impaired, you don't need to do physiology, obviously. So for all other intermediate stenosis lacking a non-invasive proof of ischemia, it is mandatory, class 1 indication, to perform some kind of physiology. And think now, who is the gatekeeper right now of chronic coronary disease? Is the ergometry? Not anymore. Is the nuclear medicine, the scintigraphy? Not anymore. Who is the gatekeeper right now? Someone tell me. The CT, exactly. So the majority of the patients that you will get on the table will not come with a proof of ischemia. So pay attention, because if you want to adhere to the guidelines, you have to do a lot of physiology. Alternative indications, not in the guidelines, but just common sense, inconclusive, non-invasive results. Sometimes it's not so clear. Or if you have an unclear target lesion, you have inferior ischemia with codominance, and both the right coronary artery and the circumflex have a lesion. So in that case, you can use the physiology just to be more accurate. Or at any point where you have clinical angiographic discrepancy, the patient comes with very clear symptoms that were very suggestive of lesions, and when you do the angiography, you don't find a clear target. So do physiology. You will come to surprises. It was usually said that with physiology you implant less stents, but if you do it properly, I think that is definitely not true. You will, especially if you are assessing proximal LAD or very proximal lesions. Pay also attention that the guidelines also only give one type 1 or class 1 indication to those tests or those indexes who have clinical studies of outcomes, direct clinical studies of outcomes. That means the FFR, which is and always will be the gold standard, IFR as rest index, and QFR as computational physiology. All the other indexes, which we have a myriad of them, do not have a class 1 indication. They are collected as class 2B. We will see them later. But so FFR, IFR, and QFR are the only ones who are officially blessed by the guidelines. Let's go through the method to assess fractional flow reserve. So the fractional flow reserve, if you take into account that flow is the gradient of pressure divided by the resistance, the FFR, the concept is the flow that you actually have distal to the lesion, so the PD minus the venous pressure divided by the resistance, divided by the flow that you should have, the aortic pressure, if you didn't have the stenosis. Okay, if you simplify the terms, you end up with this FFR formula, which is the distal pressure, here, distal to the lesion, divided by the aortic pressure. Notice that you need the hyperemia to minimize the resistance. And the beauty of FFR as compared to other indexes of physiology is that it is independent of the hemodynamic factors. Notice this case with a aortic pressure of 60 or of 120, the FFR remains the same, irrespective of the hemodynamic conditions of the patients. There is very poor agreement between FFR and QCA. And these are, there are hundreds of studies. This is published in European Heart Journal, in JACC by Bon Kwon-Koo, and some of them using very expert operators from that majority group who think that they do not need physiology or do not need imaging. And the beauty of FFR or physiology is that you have a threshold and it tells you whether you have to treat or not to treat on a dichotomous way. There is no gray zone. Still, just to, for your mental peace, if you have a very extreme value and you take the opposite decision, you are extremely wrong. But if you have a borderline value and you take the opposite decision, you are only borderline wrong. You understand? This is very important in case you perform IFR, FFR, and you get a discrepancy. I mean, just relax. Or if the patient has a very clear clinic and you get a value of 0.81, okay, if you are very close to the threshold, you may decide to take the opposite decision and you will not be so wrong as if you implant the stent with an FFR of 1. This is, I think it's important to know, especially for young operators. So the first step is to zero the curves. You have to flush the catheters with saline because the measurement of pressure is more precise with salines. You flush and then you leave the wire at approximately at the heart's height, as you can see there. And then you zero the pressure curve. You advance the pressure sensor, which is in the transition of the radiopaque zone, up to the tip of the guiding catheter. At that point, you remove the introducer, close the valve, and you equalize. So these small differences that you could still have after zeroing will be corrected in the equalization. That's when you equalize, your PD and your PA get the same, and your PDPA, simultaneous PDPA, should be 1 if you are correctly equalized or normalized. Then you advance the wire distal to the lesion, remove the introducer again, and close the valve if you have used them. And then that's the moment to measure the PDPA. The PDPA has a threshold of 0.91 to identify the severity of a lesion. After measuring the PDPA, you can measure your rest index, depending with which wire you are working. Then you measure your IFR or RFR or DFR, depending on the wire you are using. And at that point, you start with the hyperemia. I mean, if you are only using the rest index, maybe you can do the pullback. But now we are talking about the FFR. We induce the hyperemia using adenosine or papaverine or nicorandil. There are many methods. Adenosine is the most widespread. And we register the FFR. Keep in mind that the system is going to give you the lowest difference between PD and PA automatically. But the FFR is the lowest value in the steady state phase. So sometimes, very often, you will have to correct the value that the system has provided. You have to identify the steady state phase where the curves get stable and parallel, and then that's the true FFR value. Once you have recorded the FFR, remember to do this pullback again to the tip of the catheter and check that you remain normalized, equalized, that nothing has happened that is altering your measurement. If you have a difference more than 0.2, then you have a drift. If it is bigger than 2, it is recommended that you measure again. For instance, in this case, it's well normalized. But if you have a bigger difference, it is recommended that you measure again. If for whatever reason you don't want or you cannot measure again, you can mathematically correct the drift using a very simple formula, but it's easy to implement. Okay, and then you, for instance, this is a case with 3 millimeters of mercury. It's not a big deal, and the FFR is sufficient just not to be altered by the drift. Okay, if you start to infuse the adenosine or the vasodilator and nothing happens, you have to do something. First, ask your nurse to check that the venous access is working correctly. And the second one, asking the patient if he has taken some antagonist of the adenosine. And the methylxanthines are typical antagonists of adenosine. Coffee, tea, or chocolate. Usually the patients do not eat chocolate before the coronary angiography, but many of them consider that coffee is not breaking the fast that you have ordered them, and they drink a coffee before coming to the hospital, and then your adenosine is not going to work. Sometimes you could get FFR value bigger than 1. Don't be surprised. This happens typically in the circumflex or in the right coronary artery because you do the equalization, the normalization at level of the ostium, and your pressure wire sometimes goes lower than the ostium. So you have a hydrodynamic difference. If you don't have any pressure drop, you could end up with a FFR wire bigger than 1. That's no problem. What to do if you have tandem lesions with FFR, these lesions? If we measure, we obtain 0.78 distally, and between the lesions, 0.83. Which lesion do you treat? How many of you would treat the distal lesion? How many of you would treat the proximal lesion? Okay. How many of you would treat both lesions? No lesion? Okay. Why would you treat the proximal? Any suggestion? That's a very good answer. That's okay, that's the right answer. It's not the value. It's not the value, but it's the pressure drop. The pressure drop. If you want to be precise, Nico Pales and Professor De Bruyn developed a formula to calculate the predicted FFR, The predicted FFR is the FFR that will remain in one lesion if you treat the other one. Nico Piles required that you occlude a vessel and you measure the venous pressure. So we simplified mathematically the formula so that you do not need that. In this case, if we enter the value in this formula, this calculator, which is free online, you obtain that if you treat the distal lesion, you will get an FFR value of 0.83 in the proximal one. But if you treat the proximal, you will end up with an FFR of 0.93. So it was the right decision. If you want to calculate it more precise, that's the most optimistic calculation because you never correct the pressure drop 100%. So at the end, you end up with a slightly worse result if you try to measure that. Okay. Let's talk now about rest indexes. When we are measuring with the wire detects some waves. And there is a period here, which is the so-called wave-free period. Okay, then Justin Davis had the idea of measuring only in this wave-free period, hypothesizing that by doing that, if you only measure in that, you would not need adenosine because this wave-free period is a period of minimal resistance, and as you can see here, the resistance in this wave-free period is very similar to the resistance that you get after infusion of adenosine. So he hypothesized that measuring only in this wave-free period would be equivalent to FFR. As you can see, it's not exactly equivalent because the threshold is different, but it is clinically useful. We will skip the whole validation process and we'll, in these two studies, Define Flare and Sweetheart, they are very similar in design and published in the same New England Journal number. They demonstrated that IFR was non-inferior to FFR, and the cutoff value is 0.89. Interestingly, these rest indexes do not have so much interplay between the lesions because they do not require the ischemia. So you can calculate virtual stenting or the pressure drop at each lesion directly without that correction in the formula that we presented before. So it's more convenient in that sense. I don't know why. Okay. Since Justin Davis patented the IFR, Johannes van Herut developed his own resting index, then he called resting full cycle ratio, the RFR, which is now distributed by Coroventis and Abbott. It has the same cutoff value, as you can see here, and in a validation cohort has almost the same value as the IFR in all the cases. Very interesting, if you pay attention to this column, every rest index, including the simple PDPA, has approximately the same diagnostic accuracy with subtle differences in sensitivity and specificity. There are other coronary indexes, rest indexes, like the diastolic pressure ratio, which is derived from the DPDT curve, or the so-called diastolic hyperemia-free ratio, which is calculated using the downslope of the aortic pressure. There are many of them, but all of them have the same cutoff value and probably the same accuracy. However, only IFR has found a class 1 indication in the guidelines because it is the only one who has a direct clinical study of outcomes. The other ones are probably equivalent but are collected in this 2B indication, so not so much evidence. And coming to this, we come to the last part, which is this computational physiology. This slide is during my PhD in Rotterdam, and I like it because it collects the moment where we are discussing about this paper we were about to publish, and we are commenting, we were calculating shear stress in the coronary artery. And I was telling the engineers there that instead of getting so complex calculations, calculating the pressure in every segmented point of the vessel wall, we should try to calculate average pressure distal to the lesion. And they said, but is that clinically relevant? Because that would be very easy. And that was the surprise. Actually, in the discussion of this paper, which is about shear stress, we collect that the information that we were disclosing would be relevant to develop a virtual FFR. And notice that this is prior to any QFR or computational physiology development. So the engineers have better commercial views, so they decided to start by angiography. I wanted to start by OCT, that would be more accurate, but they decided to start by angiography, and they developed the QFR. Basically, the concept is, if you have a reconstruction of the anatomy, and you submit this anatomy to computational fluid dynamics, which is cumbersome, you can calculate very accurately the pressure drop along the vessel wall. In QFR, the key point is that he has simplified these hours of computation and calculation with computational fluid dynamics using a simplified algorithm. And then you can get the result in a few seconds. That is the QFR. Since QFR is based on angiography, we share the same limitations as angiography has. The calcium, the vessel overlap, the foreshortening, the poor quality of the angiography. So we decided to overcome these limitations with OFR, optical flow ratio, using OCT, which is the most accurate anatomic reconstruction, thinking that we could improve the accuracy. And we published the pivotal prospective study of OFR, and as expected, you can see that we have less constant bias than QFR and less proportional bias than QFR. We are, in overall, more accurate and correlate better with FFR, as expected. The area under the curve is also slightly better. So OFR, optical flow ratio, based on OCT, is the most accurate method of computational physiology. But is OFR in the guidelines? No, it is not, because we don't have a direct study of clinical outcomes. And it's very difficult that the technique based on OCT gathers such a big study, which costs a lot of money to perform. The only method of computational physiology which has a direct study of clinical outcomes is QFR. And that's the reason why it is contemplated as class 1 indication in the guidelines after the results of the FAVOR 3 China study, as we have seen. So the rest of angiography-derived computational physiology methods are contemplated in the 2B. And finally, just to summarize, because we are out of time, if your old lady with typical angina comes to the table, has normal coronary arteries, normal FFR, what do? Usually you go out and you tell the family, don't worry, she has nothing in the heart. And then the poor lady has to go to the psychiatrist, to the gastroenterologist, etc. Now, you know that you cannot stop at that point. If you have typical angina or if you have scintigraphy, a positive ischemia result, now you have type 1 indication to go further and to assess the microvascular function. The microvascular function, the principle is that the coronary flow is inversely correlated to the mean transit time in thermodilution. And Johannes van der Rohe has simplified the method in the Coroventis software. Pulling out the string, calculating, then you can calculate the resistance, the so-called IMR, very easily with thermal dilution. Normal values are there. This microvascular function has prognostic value. If you have normal FFR, having an impaired CFR has poor prognosis, and you have the combination of poor CFR, coronary flow reserve, and increased resistance, your prognosis is significantly poor if untreated. And now, the recent guidelines that I have criticized so much, for the first time, they proposed a combined protocol, which mixes several things. Mixes vasospasm, endothelial dysfunction, and the impaired vasodilation of microvascular dysfunction. But at least has the advantage that following the protocol, you assess everything. If you read it, it's not so clear, but summarizing, you start with doing the angiogram, then you start with low dose adenosine. If with low dose, low dose acetylcholine. With the acetylcholine, you should have, if your endothelium is working, you should have a slight vasodilation. If you don't have that vasodilation, then you have endothelial dysfunction, the first phenotype. Then you go to high dose acetylcholine. If you have changes in the ECG or pain, then you have vasospasm. If this vasospasm is obvious in the angiography, you see the lumen reduction, then you have the epicardial vasoconstriction. And if you cannot see it so clearly, but the patient is complaining, or the ECG is complaining, then you have the microvascular vasospasm. And finally, if nothing happens, then we give nitroglycerin to remove all the possible vasospasm, and we do the thermodilution. And if the values apply to microvascular dysfunction, then we have the fourth phenotype of microvascular dysfunction. In summary, physiology is mandatory in chronic coronary syndromes if we have intermediate stenosis and no proof of ischemia, which is a very common situation. Also, if we have an unclear target lesion or if there is clinical angiographic mismatch. For the epicardial assessment, the FFR is the gold standard. We have also class 1 indication for rest indexes or computational indexes, which have direct clinical studies of outcomes. And then we have a myriad of other rest and computational indexes, which are probably equivalent, but right now have a class 2B indication. Feel free to use them, use your logic. And finally, don't forget the microvascular assessment. If you follow that systematic protocol, you assess the vasospasm, the endothelial dysfunction, and the microvascular vasodilation impairment. And you can provide the patient the specific treatment. Thank you very much for your attention.
Thank you so much for your very comprehensive speech about coronary physiology. There is any question? Any observation, curiosity, something that
Just one. How do you explain the results from Favor Europe study?
From which study?
Favor Europe, the QFR study verifying the result from Favor 3 in European population.
That's honestly, it lacks me the information to make such a judgment. But for instance, QFR requires proper training. Now, one of the companies, Pulse Medical, based in China, is using artificial intelligence just to reduce this variability. But the most widespread software in Europe, which is MEDIS, still requires quite a lot of training, and there is substantial variability depending on the operators. Well, there are, honestly, I don't know, there can be many factors just to explain the poor results. Honestly, even though I was deeply involved in the development of this technology, I have always said that computational physiology is only a proxy for FFR. And it's very useful if it is reassuring. For instance, to adhere to the guidelines, you need a physiology assessment. And for instance, I mean, the clinic is clear, you have a clear target, and if the QFR is reassuring, then you don't need probably any more. Okay, you have a QFR value which suits with the clinical scenario, then you don't need any more. But in the unclear cases, which is where the physiology is most useful, then I always go for wire-based physiology, because then there is no question or no discrepancy.
So, thank you, Juan. And the next speaker will be Dr. Mileva. Yes?
Hello, everyone. I'm pleased to be here today and have the opportunity to speak, especially about coronary CT. I believe you trust me that I was very happy when I saw this topic in front of my name. But I need to be honest with you. From me, you would hear the most positive side of the story regarding CT, so it would be very hard for me to speak about any pitfalls, but let's see. So with the advent of technology, with our comprehensive machines and softwares, current technology allows us to use cardiac CT not only for evaluation of the presence of coronary artery disease. It actually helps us to evaluate for the presence of plaque and more comprehensive characterizations of the plaque itself. Even when we see calcific coronary plaque, we have the ability to assess the distribution of the plaque. Moreover, the cardiac CT allows us to evaluate not only the coronary artery tree, but also to assess the epicardial fat, the myocardial disease, the atrial disease, and last but not least, current technology actually allows us to assess also the functional significance of a coronary lesion. Using current CTs, we have the ability to assess the lesion length of coronary atherosclerosis, of coronary atherosclerotic plaque, really from healthy to healthy segments. So very IVUS-like, we have the opportunity to use CT to assess where are the healthy segments of the artery where we can put the stent in a really healthy segment. CT allows us to characterize the atherosclerotic plaque in a very high detail. As you can see on the first circles, this is the very typical low attenuation plaque with low intensity. This is usually the high lipid plaque. We see Hounsfield units below 30 and 50. In the middle, we can see the fibrotic atherosclerotic plaque, which is with intermediate intensity, and of course, the high-intensity plaque, this is the calcified plaque. Speaking of plaque characterizations and assessment of lesion length from healthy to healthy, we can really start speaking about comparison between CT and IVUS. And if we see the images here, we see a very high correlation of the images that we receive. For example, here we see a very specific sign, the napkin ring sign in CT, which is a sign of a very high-risk plaque, which indeed shows us the necrotic core in the middle and the thin fibrotic cap above the necrotic core. We see the exact same position in the CT and in the IVUS, and you see the very good correlation between the two imaging modalities. Moreover, when we speak about calcium, again, CT allows us to evaluate the calcific plaque. With CT, we can evaluate the arc of the calcium, the depth of the calcific plaque, and the intensity of the calcium in the CT. Of course, there are some disadvantages in the evaluation with CT. However, we see that now with the modern technologies, we can gain more and more information even for the calcific plaque. Of course, we cannot skip the functional assessment with CT. Thanks to modern technologies of computational fluid dynamics and artificial intelligence, we have the ability to assess the functional significance of a lesion. Here we see the software from HeartFlow, where we see red, then we see that there is disturbance of the flow. What is more important, in the last years, what was developed is actually the PCI planners. So the software that allows us to put a virtual stent and predict what is going to be the FFR after putting this stent. So you see the software is even suggesting 1, 2, and 3 strategies that we can use and see what would be the result. So we can really plan our procedure based on our FFR CT planner. Of course, unfortunately, this is a technology that is definitely not available everywhere, but it's something that we should think about and not forget as a great option that CT is giving. And all these led to the remarkable idea and the development of P4 trial developed by Carlos Coletti in a group in Aalst. about the CT-guided PCI. So using all these features of plaque characterization, plaque distribution, our data from FFR-CT pre and post-PCI to help us guide our procedure and plan every step along the way in treatment the patient. Speaking about CT-guided PCI, there is a very important aspect that we should consider, and this is the treatment of bifurcation lesions. As Professor Rigatelli already said, one of the disadvantages of coronary angiography is the foreshortening of the image and the lack of 3D visualization. However, CT helps us visualize the coronary tree in whatever projection we want, in projections that are not possible in real life in the cath lab. So I think this is a very important aspect, treating bifurcations. And here I will just demonstrate a short case with everything that I already said. So we see here a lesion in the left anterior descending. We can evaluate the vessel from proximal to distal with comprehensive evaluation of the plaque distribution, plaque characterizations, and where is the really healthy segment of the artery. What is more, we have the 3D volume rendering image. We can rotate it in whatever projection we want, just to have a really deep evaluation of the bifurcation and the angle between the main branch and the side branch. So we see here a lesion length of 57 millimeters. We see 71% diameter stenosis. We see in the middle, with the minimum lumen diameter of 1.1, a very low attenuation plaque, so probably a high lipid plaque. What is more, we can assess the bifurcation angle, so the angle between the main branch axis and the side branch origin. We see angle of 63 degrees, which may help us in the procedure in these patients. So you see the angiography of the patient, you see the LAD and the diagonal branch. Here we have only 2 projections, but we have already evaluated our vessels in the CT. So the PCI of the LAD went uncomplicated without any protection in the side branch. And you see here is the final result. So my message is that guidance of PCI with CT may be really valuable in bifurcation lesions. However, of course, we have a lot of cases with non-obstructive coronary arteries, but even there, CT can give us important information. For example, in this case, we can see that in the LAD, there is a myocardial bridge in the middle segment of the vessel. With CT, we can have a detailed evaluation of the myocardial bridge. How long is the segment that is inside the left ventricle? How deep is this segment? And last but not least, with what angle it is going inside of the myocardium, because you can imagine that the steeper the angle, the more disturbance there will be in the blood flow. So this is something that we are now doing, evaluating all patients with myocardial bridges with these 3 parameters, length, depth, and angle. And when we refer these patients for invasive angiography to measure the functional significance of the bridge itself, we saw that indeed the FFR was 0.72. Important, of course, findings may be found even that we are not looking for them. We look for the coronary arteries, but very often, not very often, but sometimes there are important findings that we should not forget, such as chest masses, such as thrombus in the left atrium appendage, such as small contrast going from a persistent foramen ovale. And this is probably for us the most common thing that we find, incidental pulmonary embolism. So now I come to the hardest part for me, speaking about pitfalls regarding coronary CT. Honestly, now with the advantages and advance in the technology, we can scan even patients that are with higher heart rate. We can scan patients that are overweight. We can scan patients that are claustrophobic. We can scan patients with a very small amount of contrast. So the pitfalls are less and less. However, To demonstrate you how humbled I was just a few months ago, I would show you a case from our practice. This is a 61-year-old man that was referred to our clinic. He had non-coronary artery disease with previous PCI in 2019, with 1 stent in circumflex artery and 2 stents in distal RCA and PD. The patient had some moderate angina on moderate physical exertion, so this was the CT. Seeing these images, I saw good contrast in RCA, good contrast in circumflex, so I was very confident when I say stents are okay, there are no in-stent restenosis. However, I see lesion in the proximal LAD, some mixed plaque with some calcium, with some lipid, so I think the best for the patients would be to be referred for functional assessment in the cath lab. So this is the invasive angiography of the patient. We see the lesion in the proximal LAD. The patient underwent measurement of FFR that was 0.86. However, when we see the right coronary artery, I am sure you can see the significant in-stent restenosis in osteopedy. And here Professor Vasilev calls me and said, here you missed something, there's something very important, you didn't see it. So I opened the CT, and again, I don't see it. Then I open the angio, and I really look for the place. And here, if we look really close, we can see that proximally, the first circle, you see the normal contour of the stent. Distally, however, you see that there is some very, very short hypoattenuation spot in the stent. So this was the in-stent restenosis that was really super focal. So one very important pitfall of CT for me is still the stented segments. Even if the scan has a very good quality, you see that it was very good quality of CT with slow heart rate of the patients. However, there are some things that we miss. In conclusion, CT provides an accurate and comprehensive assessment of the coronary tree and the whole heart. The role of CT expands much more beyond the diagnosis and risk stratification of a patient. The comprehensive PCI planning based on coronary CT may have an important role in guiding treatment strategies. However, there are still some pitfalls of the technology that we should not forget. Thank you for your attention.
Thank you so much, Nia. Very nice. I love it. And there are some questions about. I'm just a statement, and I don't know what is it. Just observation. I think that what I mentioned before, CT-based computation fluid dynamic, and we share a study ongoing, and have the, I think I have the same potential of OFR, computation fluid dynamic. Because when you overcome the fact that the angiography is only two-dimensional, and with another way, the parameter you get with the computation fluid dynamic are very useful. Not only for assessment of physiology, but also for evaluating the disease, to understand better what happened. What do you think?
Yeah, I completely agree, and I think that it's the same as functional assessment in coronary angiography, also here, and here it's even more pronounced, the qualities of highest importance here. So even if you have the smallest artifact in CT, this will definitely result in the computational fluid dynamics. So I think that this is still a very important disadvantage of the method. But if we can reach really, really good quality in CT in every patient, yes, then definitely we will have perfect results.
If I may, yes.
It is commonly believed that CT is useful to rule out because it's sensitive and has very high negative predictive value. Do you think that we are making some improvement in the other direction? Are we improving specificity in the positive predictive value?
Definitely, for me, definitely with, really, I'm not even speaking about photon counting technology because I'm still showing images from more older generation CT, but definitely we have, especially with these high-risk features in CT, we can stratify the patient's high risk, start intensive, even conservative treatment, but also refer to the cath lab.
I just have one comment because we are all here interventional cardiologists, at least most of us. And what I learned from Nia is that actually CT could be perfectly, when it is well performed, you can make a perfect plan for your future PCI, not only for CTO, but for practically almost every every patient. If you have beforehand CT images, you can appreciate well in the lesions, the calcification, the extension of the plaque, because with angio we have all these visual limitations, while with the CT, with a good quality CT, it is really possible to do even a proper, more proper stenting, even for simple lesions on the first sight, just because we cannot appreciate, for example, the whole length of the lesion by angio. You should do IVUS or OCT just to image the plaque. And this is maybe one of the very big advantages of the CT nowadays.
And what about the patients with atrial fibrillation? Are still challenging setting for CT?
It is still a challenging setting, but we saw that if we manage to reach some heart rate, even in arrhythmia, but some heart rate around 70 can still be okay.